from the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist Tony Stewart.
I wish to welcome all of you to a two-week series that we're going to do on a very important topic, and one that we have not discussed on this program for some years, and we're going to deal with the question of ethics and medicine. Bioethics is really a more appropriate way of describing what we're dealing with both this week and next week. We have very qualified guests both weeks to delve into a number of very important issues that is in that area, and I would like to introduce to you the three guests that we will have with us on the first program. First of all, to my far left is Reverend William Hemingway, who is a member of the Ethics Committee that we'll be talking about in a moment, and we're very happy to have him on our program. Along with him is Dr. Robert McFarland, who is a medical doctor and is also on that same committee, and next to him is Dr. Ted Fox, also serving on that committee. And I would like at this time to particularly thank Dr. Fox for working with me so closely over the past few weeks to put this two-week series together, and without him, this would not be happening. All three of our guests today are members of what is called the Ethical Support Committee of the Kootenai County Medical Center. And in that capacity, they have to make some important decisions that they will then share with patients and families as recommendations. Of course, they don't make the final decision. And with that in mind, I would like to proceed with our guests. And gentlemen, thank you so much for being here. Dr. Fox, I'm going to start with you because we have two things we want to get out on the table before we get into some of the basic substantive issues. And one of them is defining what ethics is. And would you just take us through that? And I know there's some other things that we should talk about in addition to ethics. What is ethos? And then also, how do we distinguish bioethics from some other ethical questions?
Well, those are difficult questions, and I've spent a lot of time thinking about them, I assure you, Tony. And I think ethos means honesty, and I think that's what we are dealing with mainly in this subject of medical ethics. I've tried to define in my own mind what we mean in this area, and I've thought, gee, why don't we just rely on the golden rule? I mean, do unto others as you'd be done by. Or why don't we go back to using the 10 Commandments? I was brought up with that in mind, you know. And somebody said that Congress passes 2,000 or 3,000 laws each year, and all they really need is the 10 Commandments. When Bob and I graduated from medical school and got our MD degrees, we raised our right hand and promised to follow the Hippocratic Oath. And unfortunately, over the years and with the many changes that have taken place in the practice of medicine, that oath has been pretty badly bent and broken at times too. So it really comes down, I think, to simply saying, doing the right thing, doing what's right. And I think that's what we deal with mainly in our committee meetings.
And when you deal with your committee meetings and you have individual cases, and later in one of these programs we're going to get into some at least case studies from the viewpoint of a simulation situation of what would be some of the factors that you would consider in making a recommendation. But in dealing with bioethics, we're dealing with life and also the termination of life that as people are terminally ill, what has to do. Would you take us a little bit through the Ethical Support Committee when it came about? I know this is something that's not always been a part of the hospitals in this country or medical centers. Tell us about the one here, when it came about, and how it is organized. And I know we have, in addition to physicians, others on your committee.
Yeah, I think it's been about 5 or 6 years ago that we were first organized, and it is something that is required of hospitals, especially Kootenai Medical Center, big hospitals, by Medicare, for one thing. That's required. Furthermore, it's now become accustomed to have a medical support committee, ethical support committee. We are made up of 10 or 11 volunteers. Joe Morris, the administrator of the hospital, Carmen Brochu, who is the supervisor or superintendent, vice president in nursing care, 5 physicians, Bob, a family physician, a surgeon, a pediatrician, and one of the doctors who's also a member of the hospital board, and myself. And then we have Pastor Hemingway, we have the hospital chaplain, and our secretary. And then we also, when we have cases to study, we also ask a layperson who is interested in this particular field to come in and be part of our committee.
Thank you. Reverend Hemingway, I want to go to you next because Dr. Fox has been eloquent in describing the definition of ethics. He's approaching it both from the viewpoint of the field of medicine and also he's mentioned the religious background. Coming from organized religion yourself, would you like to add anything, or how would you recommend that we deal with trying to define the use of ethics in this particular context?
Well, I just underscore most of what Dr. Fox said. Could I add an adjunct comment? Dr. Fox, we should not forget that there is a funeral director on that committee also. We'll get in trouble with him if we don't say that.
And he happens to be at a funeral right now.
Yes. But Tony, back to your question, which really is the pulse and the center of the discussion right now. From my perspective, the historic Judeo-Christian ethic, to use that word even, the mandate we feel from our Lord has always been, do not take the life process lightly. And then we now find ourselves in a watershed time, or a defining moment really, where we have technology that really is suitable to extend the life process almost indefinitely. And so there really are some issues, some spiritual issues to grapple with, and that's what makes this a really exciting time to be able to sit with families and share the historic positions and yet plow new ground and explore new frontiers all at the same time.
Reverend Hemingway has built a bridge for me to come to you, Dr. McFarland. With the modern technology we have, of course, we're all very cognizant of the fact that it's created situations where you can certainly make decisions or make recommendations that used to was not even possible with that technology. And I like what Dr. Fox has done in some of his presentations, where he has divided the span of a life into 3 parts. And the first part, of course, is up through birth and your early years up into the teenage years. And I'd like to start, if you don't mind, with that, and talk about some of the ethical questions that your committee may not deal as much with as they would later in life when there's a terminal question involved. But would you give our viewers some kind of an opening question, a summary of what you see as some of those early decisions, such as even a couple coming to you and we're getting into these questions, can you even determine the gender of a potential child with certain scientific methods available? I'd just like for you to feel free to walk us through some of those questions and how you see bioethics being part of that process.
Well, I'll come back at the end, perhaps, because it might be best suited for a question to handle later on about the issue of the beginning of life and allowing pregnancy to continue, because that's certainly a very topical question and has been for many years. But in the midst of pregnancy, indeed, we can make many diagnostic determinations. Probably the most innocuous and easiest one is to determine the sex of the infant. Many parents want to know that. Others would rather have the surprise package, as it were, at the end of pregnancy, and I don't have any difficulty with that. I simply do or help them to achieve what they want along those lines. Other issues involve making diagnoses of medical conditions which can affect the subsequent health of the fetus and the child who's born later. With every pregnancy, we offer parents certain diagnostic tests looking at, for instance, neurological deficits or defects which can occur. The dilemma there that every couple has to face, and that I have to spend quite a bit of time with each pregnant patient with, is to point out that for most of these conditions we have no treatment. And do they want to obtain that information when in fact there's nothing they can do other than either to anticipate the problem and be prepared for it emotionally, or if they were to choose to do this, perhaps to terminate the pregnancy. But that's a very emotional and difficult decision for most couples to face. They may not have wanted to consider the question at all of having to make such a momentous decision at that point in the pregnancy. Of course, at the end of pregnancy, at the time of delivery, then we know what the health status of the fetus is. And I think there's been a lot of work done in the medical profession and in our ethical support people from other walks of life, including the ministry and so forth, about how to deal with infants who have medical problems which would require a great deal of emotional and financial and resource application from the community and from the families.
One of the frustrations of the program is that it's so short we can't get into everything, but you brought two questions to mind that I would like to pursue with you for just a moment. One of them is, here's a layperson speaking with great ignorance, but it's my understanding that in Chicago in particular, at some of the medical centers, they have done research where through a medical method, and that there is a possibility of, before the pregnancy itself, to work with parents so that a system can be used to increase the chances of determining the gender of that child. Do you think this is an area that we'll be dealing with in the future, and it also has ethical questions that will be addressed?
I think it's inevitable that almost anything you can imagine technically will be possible at some point in the future. I hope that's not readily available in my practice lifetime. That's an issue I'd prefer to back away from, frankly, but that's something that's been attempted from time immemorial, and there have been a lot of folk nostrums, for instance, in trying to predetermine the sex of a fetus, but I'm sure that there is work that's coming closer and closer to success along that line, and of course it would be a matter of great difficulty, I think, for a physician and for parents to determine how directive they want to be in initiating life of one kind or another.
Dr. Fox?
Some work is being done at the University of Washington in that very thing, and they found that the male sperm and the female sperm swim at different speeds, and they have different weights, and they can separate the male and the female sperm so that they can use whichever sperm they want for artificial insemination, and therefore a corollary to what Bob says, it's now possible for them to determine the sex of the fetus, and a lot of people want a boy first, and if it's not what the sex that they want, of course, then be terminated. It's very interesting.
So that's another ethical question. Because
it really is.
There's one other one, and the time is really flying, but one more in this early part of life that I think that Dr. McFarland really brought to my attention. That is, suppose a child is born with tremendous physical problems and defects that will be throughout their life. There's even a question whether the child can survive. And to try to save the child and go through the process, we could be talking hundreds of thousands of dollars in this attempt that might or might not succeed. What kind of ethical questions arise there? And through all of these periods, of course, there are these questions about there's X amount of money that's available for medical care, and where do you put that emphasis? Has your committee dealt with this question in any way? And
we're just beginning to deal with that question. I would say that we're at a watershed point in the history of medical ethics. Prior to this point, medical ethics could be quickly summarized in saying do everything possible for the individual patient, and that would include for severely damaged or ill neonate who might require a great deal of cost in medical care with very little hope of ultimate success. And that was almost always provided. If the parents determined that that should not be provided, then for the most part it wouldn't be, although there are even exceptions to that. That is, there have been organizations both within the government and private individuals who feel that it wouldn't be moral to deny any level of care to any human being, no matter how damaged or what the quality of life you could anticipate for that individual would be. And they've stepped in and obtained court orders to countermand the wishes of the parents. But for the most part, if the family or responsible person related to that patient desires any level of care, we've been able to provide that. There have been resources within society to provide even the most expensive sorts of care. At this point, we're realizing that we could literally break the bank by continuing that policy. And some extraordinary interventions such as surgery now are being reviewed as to the ability of the patient or his or her insurer or the society in terms of Medicaid or other governmental agencies to pay for care. And I think we have to begin to apply that question to almost any kind of medical intervention, even ordinary everyday care. The pot can no longer grow. We've reached the limit of the resources available in the society, and if we provide expensive medical care for one individual, it has to be taken away from another.
The technology itself has created the situation to where you can provide certain care but at an incredible price. So that's why the pot is overflowing.
That's right.
May I just move on to another area? I know that you'd like to. I'd like to move to the second period. Maybe we'll have time to come back to that question. And Dr. Fox, I will direct this series of questions to you. When we talk about what we call the second third of life, I'm speaking particularly of teenage years and into the 20s, and the most largest number of people who might be considering having children, or the fertility and reproductive systems are at their greatest. We talk about birth control, we talk about abortion, we talk about the RU468 pill, which is a controversy right now. Would you, again, like Dr. McFarland did, take us through some of the most major questions during that period, and how your committee or others around the world would have to address some very, very direct questions?
Well, one of the major problems, of course, in our society at the present time is teenage pregnancy, but we don't deal with that, or we haven't so far. We have dealt with 2 cases very recently in obstetrical care, when a physician, an obstetrician, came to our committee asking just what he was obligated to do in allowing another woman who was at great risk from the standpoint of her illness, whether she should be allowed to have another pregnancy, whether he should be forced to remove the Norplant contraceptive devices under her arm. And he was reluctant to do that because he felt that in her next pregnancy she would be at great risk, because she was toxemic, she had high blood pressure, she had diabetes, and she had a very unusual blood condition. So the question was, what could he do? Was he obligated to remove this Norplant so that she could become pregnant once again? It was a tough problem, and we kicked that around for quite a while.
What is the answer to a question like that? Is that a question that in the end the patient has a right to make, or is that something that, again, what Dr. McFarland's talking about, can the medical field intervene to say the consequences of that are so great that there could be some authority other than the patient? I know that's a very, very difficult question.
We dealt with that, and we came to the conclusion that yes, the doctor has a right refusing to continue care of the patient, but first he must give that patient entire informed consent, knowledge of all the risks involved, and then tell her that he will be glad to supply all the information that he has to another physician whom she might go to.
Reverend Hemingway, I know that, again, the theological questions come into this play. How do you match some of those principles or dogma with some of these other technical questions and funding and all of this?
To just take up what Dr. Fox, and for that matter Dr. McFarland, both were talking about, it's interesting that as new as these problems seem to be, they really are quite old. There's, to use my phrase again, the historic Judeo-Christian ethic, there's always been that tension of what is good for the welfare of the corporate body, as with the tension of what is good for the human individual. And so with this particular case that Dr. Fox was talking about, it seemed to us that the child already born and the wife and the husband, that there was something to be said for what is good for those lives that already exist, let alone bringing a new one in. And so that seemed to us to be a determining factor. That tension is healthy, and it allows a good dialogue, and yet as much as we want to hold up the rights of the individual, never want to disregard the welfare of the corporate body and the for what was good for all involved.
I'd like to also deal with some of the questions in what Dr. Fox would describe as the last third of life. And again, as individuals reach a certain point and health is declining, but yet again with modern medicine, many people live longer, or there's certain medical intervention that can take place that can prolong life. But what is quality life is the way I'm going to start out. Dr. McFarland, I'll start with you again. I know some of these questions are sounding like one is playing God, but how does one deal with a patient and a family where an individual is terminal or cannot recover, and yet we have mechanisms and intervention systems such as life support systems. What is, under our term today of bioethics, is a proper definition to share with the family of how to make some really difficult decisions, both the patient, if they are cognizant of what is happening, and if they're not, for other members of the family?
Well, I'd say that it's important to keep in mind that it's much better to make these decisions before the ultimate moment or the crunch comes, when the patient is ill and we're faced with immediately choosing between therapeutic modalities or withdrawing them. And many people do that in the form of a living will, and it's certainly preferable to do that at a cooler moment when we can sit back and look at our lives as a whole and maybe gather the family around and say what we want along those lines. But as far as the physician's place in this is concerned, I would say that it is not our place to simply order every possible test or therapy that is available in order to prolong the patient's life, but neither is it our place to unilaterally determine that those shouldn't be provided, and we have to just discuss it with the patient, ideally when the patient is alert and able to help make those decisions, or if not, with the next of kin or the next closest appropriate person to help with those decisions, and really leave it up to the family. I think we're constrained morally to handle it that way, and we're certainly constrained legally, and that's something that it is important to add in this context, that the medical standard of care is defined as much by the courts as it is by what's right in medical practice, and it's always difficult to attempt to withhold medical care, even if we feel that that's ultimately in the patient's best interest, when it is available and we don't have the full consent of the patient or the responsible party.
Can I read into what you're saying, that if a person has a living will written, actually maybe even through their attorney, which is well written and specific, that if that difficult day comes when the patient's no longer able to make such a decision and maybe is on life support systems, that both for the physician and the family the problem is less. I'm not trying to lessen still the traumatic process that's going on, but you certainly can you feel more comfortable in proceeding?
Absolutely. Yeah, we can feel that the patient has already expressed his or her wishes along those lines. Of course, a living will can only be so specific, and inevitably circumstances occur which aren't exactly covered by the provisions of the living will, but at least we can feel confident in what the patient's overall desires are, or the general thrust of their desires.
Dr. Fox, you said something to me the other day that really impressed me, that I wanted you to get across to the viewers. We have stereotypes in life, and one of them is, for we laypersons, we come to our physician, we have great admiration for you and respect and your knowledge, and you certainly have saved many, many lives through that process, but sometimes we think that you can deal with everything without any hesitation. Would you share with our viewers the thought of sometimes that physicians have difficulty approaching even the family or a patient with certain things, and how the family or the patient can help you in that process?
Yes, and that has to do with the expectations of the patient and of the family. And that's one of the problems we have, even with our physicians or other physicians, because a doctor has been trained and nurses have been trained to save life and to preserve life. And then we come to this point when we have to make definite decisions. I make a practice of asking my elderly patients, now, if you were in a vegetative state, if you were hooked up to a lot of tubes, would you want to continue living? And invariably they say, no way, I would just as soon return to my God. And that's great. We should know more. That's what living wills and the power of attorney and the PSDA, which we'll probably be talking about again, does for the doctor and the patient. It's a great relief to know that a patient has made a previous decision not to be kept living if life is terminal.
Some years ago in this program, we were dealing with, at the point we are in this program, and that is, what is death? And we know, historically speaking, and we delved into that with a theologian and a scientist and a political scientist, and we look at legal definitions, medical definitions, theological definitions about the heartbeat, respiratory, and the brainwaves. In your committee and others around the world, and both from the theological viewpoint and the medical viewpoint, have we come to a more clear definition of when, even though through machinery there may be blood pumping through the body, sometimes as a person, from your perspective in bioethics, no longer with us even yet, the body is here. What I'm trying to get at in a very long question is, are we getting better at defining what death is? Reverend Hemway, would you like to start?
Well,
How about that, Bill?
In deference to my two good brothers here, I'm not so sure we haven't muddied the waters a little bit with our technology. I don't think that it's clear in my 25 years of dealing with death and the dying that I don't think it's any more well defined than it was 25 years ago.
This is a very important question because this comes up with organ transplantation. We have to be sure that the patient is absolutely positively gone before the organs can be harvested, as the saying is. It's a real problem.
Dr. McFarland, how about when, with the technology we have, that someone's been in a terrible accident, brought in, and they've instantly been put on life support, so forth, and with the technology you have, the brain waves are gone. How do we deal with a case like that? And we might still keep the respiratory system going for years.
Well, I would say that I think that the clinical definition of death is somewhat clearer than it was, say, 10 years ago, and it does relate to brain death. And if there is no activity at the deeper centers of the brain, we know that person is not going to come back, at least as a human being, as we recognize the qualities of human life. And in that situation, generally, after a matter of time, that is, we always want to give the individual some time to recover if there's any potential whatsoever. And sometimes that's a matter of weeks on life support systems. But generally, and I think this reflects the fact that the public at large is better educated because of what's available in the media, including programs like this, they've considered that question, the family's considered that question, and for the most part, there isn't a great deal of difficulty in coming to joint decision on the part of the family to withdraw life support after every reasonable period of a trial of treatment has been exhausted.
We have about 1 minute left, Dr. Fox, and I wanted to ask you as we close, with the ethics or ethical support committee you have, has it made the work a little bit easier for both the physician and the families?
Well, I hope so. We've had good success in most every one of the cases that we've been called in to study, and it's been a real, well, not exactly a pleasure, but a little triumph at least, that we were able to be of help to the family and to the physicians in this sort of a problem. I might mention in regard to what Bob said, it's easy to put these life support systems on, but it's very difficult to take them off.
I have that note. We have to bring our program to conclusion. Gentlemen, thank you very much. It's been most informative. We just got started. We're going to continue next week with some other aspects of ethics in medicine, and even though two of you won't be on that program, we'll have to have you back another time to carry out what we just started. Thank you very much.
Thank you.
Thank you.
Ladies and gentlemen, may I invite you to be with us again next week at this same time when we will discuss ethics and the practice of medicine, and we will have 3 guests that week. Please be with us then. Until then, have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Telemedia Services on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station. From the College by the Lake, Coeur d'Alene, Idaho. Local, regional, national, and international guests discussing the issues and topics affecting the way you live are on Forum, the North Idaho College Public Forum, with your host and moderator, political scientist, Tony Stewart.
We welcome you to the second week in a 2-week series entitled Ethics in the Practice of Medicine. At the Kootenai Medical Center, there is an ethics committee that deals with these issues that we're dealing with. In fact, it's the Ethical Support Committee at that center, and we're very pleased to have 3 members on as guests today. And last week we had 3 guests for you who are with us, and we're going to continue that very, very important topic that we were dealing with last week. I welcome to the program, first of all, to my far left is Joe Morris, who is the Chief Executive Officer of the Kootenai Medical Center. And next to him is Carmen Brochu, who is the Vice President of Patient Care at the Kootenai Medical Center, and then Dr. Ted Fox, who's been with us on the program a number of times and is on that committee, and I should add that Dr. Fox has served in many capacities in our community, including working with us together in the creation of hospice in North Idaho some years ago. And I also want to tell our viewers that it's Dr. Ted Fox that's responsible for these 2 weeks programs. We talked some time ago, and he's done almost all the work in bringing it together, both as to subject and guest, and we want to thank him personally for that. Dr. Fox, we always have some viewers one week that we didn't have the week before, and I think we would leave them out on a limb if we didn't go back and define what do we mean by ethics, and particularly in the field of medicine.
Yes, we tried to make up our mind in regard to the definition of this word, and I don't know, it seems to me that it has to do with social responsibility. I think it has to do with caring, and certainly it has to do with honesty and truth. And this is the concept that we function under in the working of our committee. It's a hard definition to make. I sort of like the Golden Rule and the 10 Commandments, and as I probably have mentioned before, when we physicians raise our hand and swear to uphold the Hippocratic Oath, we do that as a symbolic gesture, but we know now that this Hippocratic Oath is somewhat bent and broken over the years because of the developments that we have seen in the practice of medicine and in healthcare in general.
Joe, I'll move to you. I've known you for a very long time, and you've been a very successful CEO at the medical center. It's had a reputation of being very well run. This component that we're talking about here, the ethical support committee, is something new, I think, a few years old. Would you tell us briefly about it, and also are cases automatically referred to the committee, or are those optional?
Well, actually, it's been around about 10 years, since 1983. We had a federal requirement to start an infant care review committee to make decisions about the care of newborns in certain circumstances, and we've never reviewed such cases. We just sort of evolved it into a ethical support committee for sort of a generalized use. It's an optional committee is the way I would put it. Cases are brought to us on an optional basis. Nothing's required to be brought to us. They can be brought to us by families, physicians, and we found as we've been around for a while, they're brought from outside the hospital by people in home health or people in nursing homes. Our advice is optional. And we say this is what we think should be done in these circumstances, but the physician, the families, take that as guidance, and they're not required to follow it. And we think that is less threatening and works is the best model available.
I want to get into an area, of course, you certainly would have expertise in. That's the whole question of financing, and you spend a lot of your day worrying about the funding and for medical care. In 1992, on the national level, in addition to the whole question of deficit spending and the budget and priorities there, I can't recall an election a long time when there were so many issues that were discussed in depth, and the interest of the voters was so high. And one of those, of course, is the whole issue of medical care. And approaching from this ethical question, medical care has become very, very costly and very expensive around the world, and including this country. Not only the issue of hospitalization care there, but just the whole question of individual or families' care. And there's some obviously changes coming. I know you've been to Washington, D.C. recently and observing some of those that will be taking place in legislation. I have a very broad question for you, and that is, what are some of the ethical considerations should we have in mind when we bring about some of these changes in cost and therefore services in medicine?
The term used right now in Washington, D.C. is the term global budget, which means you put some type of cap on what we're going to spend in healthcare in this country. And to put a cap on what we spend on healthcare, you have to have some control over the price of things, but you also have to control volume. And to me, controlling volume means rationing healthcare. We as a country are going to have to decide what we're going to spend our money on if we're going to get a handle on healthcare cost. And hospitals and physicians aren't the ones who should do that. I think our society in general should decide where do we want to spend our money. You know, there have been some efforts in the state of Oregon and others to try to come to grips with that. Most often we put it off and just let technology develop on its own, hoping that someone will make a decision as to how it's going to be applied. But any type of healthcare reform will require rationing of healthcare, and that will require some decisions as to what we're not going to do in the way of healthcare.
I think you made a very, very important point, and a lot of our viewers may not be tuned into that. It's just now developing. So I hear you saying, and there might have been misconception among a lot of the citizenry, that really as health care givers that you don't really want to make that overall policy decision?
We're forced to do it now. People show up at our doorstep. We take care of them. If you show up at the doorstep of a hospital to have an organ transplant or bone marrow, you can't get in the door unless you have health insurance. And so we ration based on your access to health insurance to some degree for the real high-cost procedures. I think physicians and hospitals aren't the ones to make those decisions. I think communities need to make those decisions. Society needs to make the decision as to where we'll spend our healthcare dollars. But you can't have everything in healthcare. The technology is outstripping our ethical ability to keep up with those decisions.
I guess I have a question for both you and Dr. Fox, then I'm going to move into the personnel with Carmen. And I have the advantage of meeting with you earlier and discussing this. You've brought to mind once again that in rationing health care from the cost viewpoint, that obviously we're addressing Medicare and Medicaid and insurance companies and what they would cover and so forth. But what if individuals come in who are extremely wealthy and they don't need any financial contribution from any other source, and they demand certain care that's terribly expensive and also is time-consuming on the personnel? Is public policy going to have to address that too? Do they have that right if they have those financial means to do it?
They have that right, but right now they're treated no more differently than the Medicaid patient or the indigent patient, at least at our facility. They all have right to the same care.
But I guess what I'm really asking is something else. I'm asking that if we make a public policy that there's only so much money in Medicare and Medicaid and so forth, then certain things won't happen or certain organ transplants won't take place, but someone can afford it themselves, would they be treated in a different way and an exception to that process?
What evolves is the two-tiered system. Those covered by the basic health plan and those who can shop anywhere in the world. You see that now. A lot of the world comes to the United States, the very wealthy, to have the best in health care that's not provided in their country. And so I think as you do provide health care for all, you don't provide for the same amount for everyone. Those who are wealthy do evolve to another tier. So the question is going to be, what is the gap? At what level is the basic benefit provided, and what is the gap between those who can afford to have anything in the world?
Dr. Fox, I'll ask that question a little bit different way to you, and that is if there's only so many rooms for surgery and so many beds and so forth, and we have to choose between those who have the wealth and others in relation to policy that restricts them, is this an ethical question that gets us into quicksand?
Well, it certainly does, and it is an ethical question that we're going to have to face up to. Particularly in organ transplants, we're going to have to decide whether age or the quality of life or the value to the community or the severity of the disease, who's going to make that decision? That's the big problem, and I presume there will have to be bodies such as these ethical support committees to help with those decisions.
Carmen, I want to come along that same line with you, because all of you are so highly qualified to deal with all of these questions, but I was so interested in what all of you told me, and I really zeroed on what you said to me the other day, dealing with a process that, again, a lot of laypersons like myself would not be aware of. It's my understanding from our conversations that a lot of licensing is taking place in states about who can do what in the hospital and personnel. And now with this, what Joe's been talking about concerning maybe some new legislation nationally, can we address some of the medical costs and therefore have more money available for direct care if we address the role of the federal government compared with the role of the states in licensing? And you're going to need to really define my very vague question.
I think you're referencing the ability for us to do cross-training in a hospital setting, and whether licensure laws in the state have any barriers to allowing us to do that. Hospitals all over the country are looking at avenues and ways that we can provide the highest quality of care in the most efficient way. And one of the current strategies across the country is to really move towards maximizing the utilization of our staff. And in order to do that requires a great deal of cross-training and professional training and still maintaining quality.
Can I interrupt you just for a moment? Because again, I feel like a lot of viewers like me, they may not understand what cross-training is. Under the present system, does the licensing system say that only certain individuals can do certain things?
In some states, every state's somewhat different. Licensure for nurses is fairly consistent across the country, but there are various other specialties in healthcare that can attain licensure status in a variety of states. An example would be whether a respiratory therapist is licensed in a state or not, and not all states require that. The same thing might be true of dietitians. The same thing might be true of X-ray technicians. If you begin into a mode of looking at operating efficiently, and cross-training would be allowing an individual to do more than one job, possibly having a clinician do x-rays as well as take EKGs, as well as do respiratory therapy treatments, as well as give nursing care. When you start moving people into those various dimensions of care, you may operate more efficiently. But there are sometimes in some states some restrictions to that by licensure, and that different state licensing across the country may curtail that ability to do that, and those laws may need to be looked at.
Joe, you know, again, we were talking earlier about this. I have a two-part question to you as an administrator that you are. One is that if there's not that cross-training and all, does that require you to have more personnel on a shift than you necessarily would need if each person has to do just a very specific function?
Sure, we have found in some departments where everyone has one job, we might have 28 people. Where everyone knows their job and 2 others, we might have 18. And so cross-training does give you a chance to be a little more efficient as you get rid of some of the dips and valleys of how busy someone is during the day when they're specialized. And the more generalized they are, the more they can fill in during times when their particular specialty is not in demand.
The other thing is that I would like to, and I know we're asking you to look into a crystal ball because the package is not even before Congress yet. At the time we're taping this program, I should add that we're taping this in February, so if it doesn't air later, it doesn't look like that you're unaware of certain developments that take place. But some of the federal legislation that may come down, will it address what Carmen has just discussed concerning maybe mandating to the states that there are some things they may not be able to do because of the cost?
Oh, sure. I think the federal government, in certain laws right now, self-insured employers are not susceptible to the state mandates, and so I think the federal government, I looked at one of Stark's bill, Representative Stark's, that came out recently, and it overrides the state's ability to set insurance rates, to set mandates for health benefits, and so I think the feds will try to create some consistency across the country and eliminate some laws that they think contribute to the cost of health care.
Mm-hmm. Carmen, another thing that we talked about before the program today, and again, it's federal legislation, and it has a real close relationship to what we're talking about concerning the Ethical Support Committee, and that is a piece of legislation called the Patient Self-Determination Act. Mm-hmm. Would you share with our viewers what that is and how that relates to some of these ethical decisions that are in that process?
The Act really has brought about a great deal of new discussion in the hospital setting. The Act specifically stated that a hospital would be required to ask of a patient who's over 18 years old, anyone that came into the hospital who was over 18 years old as an inpatient, if they had a living will. And that would mean that if they did not have a living will, that we would be available to provide them information on how to access a living will, what is a living will, and allow them some education in terms of how to go about attaining a living will. I think it's the first step of the federal government, in a sense, to say that the community, the society, has a responsibility to start looking at the issues in terms of life determination. How do they, under what circumstances would they want to survive, depending upon the degree of their illness or the degree of a tragedy that they may be faced. The living will, along with another instrument called the Durable Power of Attorney for Health Care, are both parts of that act. Idaho being one of the first states with the living will, we were pretty well entrenched with the utilization of that, although not well educated in the public. The Durable Power of Attorney for Health Care is another piece of legislation or official tool that can be signed by a family to denote who would be responsible in a family to make health care decisions in the absence of that individual's own ability to do so. If they come in and they're not in a condition that they can speak for themselves or articulate them for their own self, the Durable Power of Attorney for Health Care would name an individual who would make that decision. I think the most important thing about both of those instruments is that they're freely available to the public. There's good education on how to access them and what to do with them. The other aspect is that they are instruments that allow the families to start talking, to start defining terms of living and under what circumstances and what is quality of life and under what circumstances would you tell a physician that you didn't want something done. The other, or at what cost of making a very costly decision in health care, and and what impact that would have on the family finances, and is it worth living under those quality measures. And that conversation should go further than just with the immediate family. It should go with the patient's primary care physician, whoever that might be. Dr. Fox, I'm sure, has had many such patients converse with him as far as having a living will and durable power of attorney for health care. We're required to make a copy of that and have them available so that we can guide our care at the hospital and use that as an instrument of guiding and communicating with the family.
Certainly makes life easier for families to have this kind of assistance from you at a time when it's very difficult.
Well, I think the most important piece of that is that they're doing it at a time that they're healthy. Yes. And that they have all their wits about them, they have their good health about them, and they're in a position to make that without being stressed.
Dr. Fox, you have also mentioned to me before that sometimes family members are disagreeing, and does that make this whole process a lot more difficult to even address?
Yes, in these terminal cases, that is a real question. Tony, may I make a little overview remark here? I was just thinking as I listened to all our talks, and I've thought a lot about this too. When I came to this community in 1939, we didn't concern ourselves with money, and now money is mixed up with medicine. And all of these things don't come from the physician or from the hospital, they come from government, of course. And in those days we had maybe 5 or 6 or 8 or 10 drugs, morphine, strychnine, all the different minor things that we used to use. We carried our own bags. I wore out 3 bags on house calls. I delivered babies at home. Now these things are all different. We have these beautiful, beautiful medications. Some of them are horribly expensive. We have had one experience in the hospital where one course of medication cost $60,000. And we have beautiful technology in the hospital. It's just marvelous, but it all costs money. And probably a lot of the public do not realize how the impact of cost comes from technology, and that's a real problem.
Joe, you have a board of directors, and I know they're elected, and you obviously have to make policy decisions. And what Dr. Fox has just said, sometimes when you're being encouraged by physicians or by the general public, whomever, to say there's certain modern equipment and techniques available that you don't have at other places, or you've gotten them recently, but there's a price tag with that. How do you ethically also deal with what Dr. Fox talked about, this skyrocketing care, and as we commit ourselves more to that, are we tied more and more to money in making those decisions?
On the equipment, it's not a difficult decision, I don't think. We look at what the potential volume is here, whether we would do enough of it to be good at it, whether we can do it at a price at or below where it's done elsewhere, and so that's the equipment decision. We make that very thoughtfully. We don't make thoughtful decisions on what drugs we stock in our pharmacy. Right. And if we stock a drug that costs $5,000 per dose, the whole treatment's going to cost $50,000 on a terminally ill patient where it has a 20% chance of being successful, and if successful, it may extend life for 6 months. Is it ethical to do that? And in the first years of our ethics support committee, we only brought patient care decisions. This year, for the first time, we've come to that committee and says, is it ethical to spend $50,000 community money, $50,000 of money on this patient under these circumstances? And we've started to wrestle with where can we spend our money, where can we not spend our money? And we've only been forced to do so because of these genetically engineered drugs that have come out that are going to come out even more explosively than they have now. They're going to make us try to make those decisions as to where the money goes. And so our biggest worry are the drugs that are coming down the line.
Let's pursue that a little bit further. You know, we talked on the first show about there's so much money in the pot. And Joe, you talked about on this show that the public may have to arrive at some public policy decision. This is all you get. We are having more and more patients, and Dr. Fox referred to one that with us last Friday about that tremendous cost can go in $30,000, $50,000, $75,000, and you know from that treatment that the person will live 3 or 4 months longer, and yet that money, as some of you indicated, would run whole programs for 1 or 2 years. If, let's suppose that the public policy decision is you'll still go ahead from say it's an ideological decision or philosophical decision, that care will be available to the first come, first serve. Is there any way that we're going to deal with that ethically when that person who comes in and it'll prolong their life for 2 months gets it and it's spent, and then someone comes in that there could be a treatment that would save their life, but the money's not there.
We discussed that very option at our last meeting, and we decided, no, that's not going to work. And so we need to develop criteria for allocating dollars. We said we may need to develop a budget for how much we can afford to spend for patients who have no reimbursement for these types of things, but we felt it was better developing criteria than just saying first come, first get, because the most deserving might be the one who comes after you've spent the money.
Mm-hmm. Carmen, would you like to address that in relation to also your personnel that you supervise and all?
I think the question, even my staff ask a great deal, because they have to administer the therapies, and they're in the midst of that too, and they wonder if it's worth the expense that they know that they're expending in taking care of a patient too. And I think the greatest point of that question is, does the patient have a choice? Did they get informed? Do they have enough information to know the consequences of going forth? One of the dilemmas that we discussed was that we wouldn't start someone on such a therapy and then withdraw it. That it's just like on extended life support measures. It's easy to put somebody on something, it's hard to take it away. The same question would go with these types of therapies. If you start someone on an expensive route of medication therapy, it's very difficult to stop halfway through and say, sorry, the pot's empty. And so now we're at a point where we're having to ask the tough questions. You know, who do we start on a therapy like that? And have we informed the patient's family of the full spectrum of the cost associated with that and making those decisions?
I have another very sensitive area to get into, and I certainly want to preface it by saying that the Kootenai Medical Center, from all I hear, is really well run, and I'm not referring to the Kootenai Medical Center and many others around the country, but there have been investigative reports by some national media that indicate that, like in all professions, that there are some abuses, and that it has been charged or alleged that some drugs have had tremendous profits, not for the medical center, not for the physicians, but for those producing them, and that also there's even been some chains of medical hospitals that have, at least it has come out in reports that they could buy something for 45 cents and sell it for $49.50, and we had a person here from Idaho State University who's in charge of their programs, and she was very eloquent in describing this. Is this the kind of thing that government's got to address too in this ethical question, if those abuses are taking place, as has been alleged by some investigations?
I appreciate your first disclaimer, but
yeah.
I think there will be, the drug companies are under fire and the cost of drugs is under fire. You know, we buy through a purchasing group that buys $4.2 billion worth of supplies, and so we get good buys on drugs. Our markup is pretty meaningless in that only 35% of our patients actually pay what we charge. Most are on fixed cost or don't pay us at all. I think as part of national health care reform, they're going to look at drug companies, and they're going to regulate, as other countries do, what drug companies can charge. Certainly the same medication in Canada by the same company costs a lot less than it costs in the United States. My drug stock that I own has gone down 25%, anticipating that change coming next year, or this year.
Yes. I have another question. This is for all of you, and it's a very philosophical question. I really sympathize with you. You have my life seems simple in decision-making compared with yours, and you've chosen a profession where that's very difficult. But there are differences in political philosophies in our country and all countries. And some individuals feel very, very strongly that certain information shouldn't be available to the public through sex education or whatever it may be, or dealing with, in the school systems or in the public in general, dealing with such issues as how to prevent AIDS and so forth. And the other side of that coin is that if you don't provide the information, then there are going to be more cases of AIDS or other transmitted diseases and so forth, and then it's on you not only to try to help those individuals, and in many cases they become terminal, and also the cost. How do you respond to those that say, let's don't discuss it? Dr. Fox, we'll start with you.
Well, of course, I'm all in favor of education, and that's why we're here today. On the other hand, there is the point that we overeducate our public, and they have higher expectations which probably cannot be met because of the financial stress. In other words, we cannot provide a $1,000 MRI for every person that has a headache or a backache, but sometimes that is being requested. That's a problem. The other problems is that we physicians are being shackled a little bit by federal government and other agencies which will not allow or will deny the treatment that we order at the hospital, for example, and the hospital will lose money. We are governed by the DRGs, which allow only so much money to the hospital for each individual type of a case. that's a problem.
Carmen, about 2 minutes left.
I think on his point, in terms of making making those kinds of decisions, I would say all the education possible is the best way to go, that the public and the consumer should have every bit of information on preventive health. That the more you educate on that, the more onus of responsibility lays with them. As far as educating them on the use of what prescriptive medications, antibiotics, MRIs, high tech, I think that needs to be left with the physician who's prescribing. But preventive, yes.
And Joe, you're a supporter of the preventive medicine
I would agree
approach.
almost entirely with Carmen that the more information people get, no matter what the age, the better it is, whether it's sex education, whether it's being accountable for their own health care, whether it's rationing health care. I have great faith in the American people to make the correct decisions, to be able to, in an intelligent manner, take the information in and develop a value system of their own. That's the reason we've wanted to come and do this program. And we're starting to discuss the cost of health care, what we do and what we can do and we cannot do. And we think that we don't want to keep it in our committee. We want it to be discussed by the public in general.
On that note, I'd bring the program to conclusion, but I just want to say we got started, and you have done an excellent job, as happened last week, in trying to inform the public. That's what this program is all about. And I want to say to you and all, and Dr. Fox in particular, we want to continue this in the future. And I would really like to do some programs where we deal with some specific types of illnesses and deal with your very talented staff in doing that. Thank you for your time today.
Thank you, Tony.
Ladies and gentlemen, we've certainly just opened the door to this question, and I think you would agree to that. It's terribly important, and sometime in the future we will continue these discussions. Please join us next week when we will discuss a different subject. Until then, please have a good week. I am Tony Stewart.
The North Idaho College Public Forum was videotaped live from the studios of Telemedia Services on the campus of North Idaho College for viewing at this more appropriate time. We invite you to join us again next week for another all-new edition of the North Idaho College Public Forum on this public television station.